whenever we are thinking of interventions for these patients, we want to make sure that we're providing a high-calorie, nutrient-rich diet. Now, in order for these patients to achieve this, we might have to put them on a feeding schedule of 6 small meals a day, and we might have to include supplemental drinks like Boost or Ensure. Sometimes these patients may have problems chewing or they are edentulous, so we have to keep that in mind as well because a puree diet may be easier for them. Now, there's a chart on page 1240. It's chart 60-3. It says nursing focus on the older adult, promoting nutrition intake. So if you'll read over that for the older adult, beginning on page 1241, we are looking at total enteral nutrition. Those who can eat but can't maintain adequate nutrition by oral intake are typically patients that are candidates for total enteral nutrition. Those who have neuromuscular impairments or those who cannot eat because of their condition are candidates for total enteral nutrition. Now, methods of administering total enteral nutrition, we have nasal enteric tube, and that's when the tube is inserted nasally and then advanced down into the GI tract. For you all, you are familiar with the NG tube. Now, keep in mind the NG tubes are to deliver short-term enteral feedings, typically less than 4 weeks. Now, enterostomal feeding tubes, these are long-term. These are those gastrostomies and jejunostomies. They are placed surgically, endoscopically, and sometimes laparoscopically. Now, gastrostomy, that's when the stoma is created from the wall of the abdomen into the stomach, okay? It's typically placed endoscopically and then referred to as a percutaneous endoscopic gastrostomy, so a PEG tube. Now, we do have such things as low profile gastrostomy device. That's LPGD. These are good because they have an anti-reflux valve that keeps any contents from leaking onto the skin, so it's a less irritating device. Now, jejunostomies are used for long-term feedings whenever we want to bypass the stomach, okay? Now, tube feedings are given in bolus, continuous, and cyclic. Bolus is when we have a specified amount of product and we give it at a certain interval. About every 4 hours we give boluses. Now, you can do a bolus manually or by infusion with a pump. Our continuous feedings, they're similar to IV therapy because small amounts are continuously infused over a certain period of time. Now, we also have cyclic feedings. Now, cyclic feedings, this infusion is typically stopped during a certain time, maybe 6 hours or so, to allow downtime for the stomach. Okay, now whenever we are feeding patients and focusing on enteral nutrition, we want to remember patient safety. Okay, X-rays, they help to confirm the placement of the tube. Now, capnometry is also used whenever our patient is having a tube, okay? Especially because if the test is positive for carbon dioxide, then that means the tube's placed in the lungs rather than the stomach, okay? So on page 1243, there's chart 60-4 and chart 60-5. We have tube feeding care and maintenance and maintaining a patent feeding tube. So if you'll look over those two charts. Now, we have to make sure that we do not overfeed these patients, okay? We want to make sure we're checking gastric residual volumes every 4 to 6 hours or depending on facility. Typically, the Aspen recommends holding a feeding if a gastric residual is more than 200 mLs on 2 different assessments, okay? Patients receiving enteral nutrition therapy, they're at increased risk for fluid imbalance, so we want to keep that in mind when we're making our nursing diagnoses. Diarrhea can develop because the food or the enteral preparation is delivered too quickly or because it's too hyperosmolar. Okay, that situation can also lead to dehydration. Now, it's important to remember that some medications have high osmolarity. So when we're thinking of Tylenol, Lasix, and Dilantin, patients receiving these types of liquid drugs may need these drugs diluted, or they may have to change to a different drug to prevent diarrhea. Okay. Electrolyte imbalances, we see hyperkalemia and hyponatremia. We can also see hyperglycemia because of the hyperosmolarity of the plasma. Now, when we talk about partial parenteral nutrition or PPN, that's when it's given through an IV. Now, we typically call it PN, and then we have total parenteral nutrition, and that's TPN. TPN and PN both go through the veins. PN is typically distributed through just a regular peripheral IV, and that's when the patient's not able to take in enough nutrients to meet their needs. Now, TPN is when the patient needs an intensive nutrition support. Okay, TPN is delivered through a PICC line or a jugular vein or a subclavian vein. Now, TPN solutions, they have higher concentrations of dextrose and proteins than PN does. But when we're talking about patients in general that are receiving parenteral nutrition, they're at high risk for fluid imbalance because of the extreme hyperosmolarity, and dextrose can induce hyperglycemia. Okay, so we want to monitor for complications. We want to take daily weights on these patients. We want to make sure we're getting an accurate intake and output on these patients, and we also want to monitor their glucose levels, whether they're diabetic or not. Most of these patients are going to have a sliding scale, and we also want to monitor their electrolyte values. Now, these patients, again, we want to make sure that they have the correct financial resources at home. We want to make sure that we're teaching these patients about high-calorie diets, high-protein diets, and nutrition supplements. We want to make sure that if they're using iron, they want to take that drug with meals. And we need to caution these patients that iron can lead to constipation. In the next audio, I will begin with obesity on page 1246.